Welcome to this Step 3 review on cost-effective care. This video is brought to you by Roadmap to Residency. Cost-effective care is one of the highest yield themes on the entire exam, and it shows up across almost every organ system. Our goal today is not to reteach medicine. It is to show you how the question stems are built around cost, value, and appropriate care, and exactly how to attack them. We will cover choosing wisely principles, avoiding unnecessary testing, generic versus brand medications, and reducing hospital readmissions. Make sure you are also working through a question bank and a trusted review resource alongside this video, because these patterns stick best when you drill many practice questions. Let us get started. Here is what we are going to cover today. First, you will learn to recognize when a question is quietly testing value and cost, even when the word cost never appears in the stem. Second, we will lean into the themes that this exam loves, which are choosing wisely, avoiding unnecessary testing, favoring generic medicines when they are equivalent, and building discharge plans that keep patients from bouncing back to the hospital. Third, we will walk through several practice questions together and reason out loud about why each answer choice is right or wrong. This video assumes you already have the underlying content from your question bank and a trusted review resource. Our job is to sharpen how you take the test. Our first strategy is the choosing wisely mindset, and it underlies almost every cost-effective care question. Start by asking a single question about any test or treatment in the answer list, which is, would the result actually change what I do for this patient? If a test will not change management, choosing wisely tells you not to order it, and the exam agrees. The choice that gathers a genuinely useful piece of information at the lowest cost and lowest risk is usually the one they want. Then remember that more care is not better care. This exam rewards proportionate care, so be suspicious of answer choices that pile on scans, referrals, or admissions the patient simply does not need. When a focused history, a counseling step, or careful, watchful waiting sits right next to an aggressive workup, the restrained choice is very often the correct one. Train yourself to notice that pattern every single time. Strategy 2 is avoiding unnecessary testing, and this is where the exam separates careful readers from the rest. First, learn to find the absent red flags. When a stem walks you through a string of reassuring negatives, such as no fever, no weight loss, and a normal exam, it is quietly handing you permission to skip imaging. Those absent red flags are the single biggest clue that the impressive scan in the answer list is a trap. Match the intensity of testing to the patient in front of you, and let a reassuring history and exam push you toward conservative care. Second, do not repeat what is already known. The exam loves to plant a test that simply duplicates information the stem already gave you, or a screening study that is not yet due. Before you choose any test, check whether the answer is already sitting in the vignette. Ordering it again wastes money for the patient and costs you the point. Strategy 3 is generic versus brand medications, a small topic that shows up more often than students expect. First, default to the generic. When two answer choices offer the very same drug, one as a generic and one as an expensive brand name, and nothing in the stem demands the brand, the generic is both the cost-effective choice and the correct answer. Generic medicines meet the same standards as their brand counterparts, so the exam rewards choosing them by default, especially when the patient mentions cost or difficulty affording their medicines. Second, watch for the cost barrier clue. When a patient tells you they skipped doses because a medicine was too expensive, that is a giant signal to switch to an affordable option in the same class, rather than piling on new drugs for what looks like non-adherence. Fix the cost barrier first, because the medicine a patient can actually afford is the one that works. Third, know the rare exceptions. A few narrow therapeutic index drugs, where the stem emphasizes tight monitoring, can favor staying on one consistent product. But these are the exception, not the rule. Unless the vignette gives you a concrete reason, treat the generic as equivalent and let cost make the decision. Let us work through our first practice question, which is built to test avoiding unnecessary testing. A healthy 35-year-old woman comes in for a routine annual visit. She has no symptoms, takes no medicines, feels well, does not smoke, and has no family history of early heart disease. Her vital signs and exam are completely normal. She asks what testing she needs today. The question asks for the most appropriate next step. Notice how hard the stem works to tell you she is low risk and has no complaints. Read the 4 options carefully, ask which of them would actually change her care, and pick your answer. Then we will walk through the reasoning together on the next slide. Let us break this down step by step. First, spot the pattern. This is a young, symptom-free, low-risk adult at a routine visit, and the stem piles up reassuring details on purpose. There is no complaint here for any test to work up, which means this is a screening and prevention scenario, not a diagnostic one. Second, apply the rule. For a healthy, low-risk adult, appropriate care is simply the screening and counseling that is due for her age, such as checking blood pressure and offering routine preventive services. No cardiac testing and no broad laboratory testing are indicated. Third, eliminate the wrong answers. Ordering a heart tracing and a stress test in a symptom-free, low-risk person is the classic unnecessary testing trap, and it can even trigger false positives that snowball into more testing. A whole-body scan mostly finds harmless incidental findings while driving cost. A broad panel of blood tests with no indication does the same. The correct answer is to provide age-appropriate screening and counseling only. Notice how the choosing wisely mindset pointed you straight to it. Here is our second practice question, and it is all about generic versus brand medications. A 62-year-old man with high blood pressure comes back to the clinic, and his pressure is above goal today. He admits he has been skipping doses of an expensive brand name pill because he cannot afford the monthly copay. He has no side effects and no other complaints. The question asks for the most appropriate next step. The crucial clue is that the real problem is not his disease and not the drug. It is the cost barrier that is keeping him from taking it. Pick the answer that fixes that barrier, and we will reason through every option on the next slide. Let us work through this answer. First, find the real problem. The stem tells you plainly that he skips doses because of cost, and that he has no side effects from the medicine. That means his pressure is high because he is not taking the drug, not because the drug failed him. The problem to solve is affordability, so the fix is a medicine he can actually pay for. Now, why does the generic win? Switching to an equally effective generic in the same drug class removes the cost barrier directly and is the cost-effective and correct answer. Adding a second brand name medicine treats a failure that is not real and simply adds more expense. Admitting a stable patient to control blood pressure in the hospital is wasteful overkill, and telling him to keep buying the brand and try harder to pay ignores the very problem the vignette put in front of you. The correct answer is to switch him to an equally effective generic in the same class. Strategy 4 is reducing hospital readmissions, which the exam tests through the everyday work of a safe discharge. First, nail the discharge bundle. When a STEM is about sending a patient home safely, the correct answer is almost always one of the transition of care steps, such as reconciling the medication list, giving clear written instructions, teaching the patient which warning signs should bring them back, and confirming the patient actually understands the plan. These humble, low-cost steps are exactly what prevents the patient from bouncing back, and that is what the question is really testing. Second, book the follow-up before discharge. Early follow-up is a favorite right answer, because arranging a clinic visit within about 1 to 2 weeks, especially after a heart failure admission or another high-risk stay, sharply lowers the chance of readmission. When the answer choices pit prompt follow-up against more inpatient testing or a distant appointment months away, the timely follow-up that closes the loop is usually the one they want. Here is our third practice question, and it rewards the readmission reduction mindset. A 70-year-old man is ready for discharge after treatment for a heart failure flare. He now breathes comfortably, his weight is back to baseline, and he is medically stable to go home. 2 important details stand out, which are that he lives alone and that the team changed 2 of his doses during the stay. The question asks for the most appropriate next step to reduce his risk of coming back to the hospital. Think about what actually prevents a bounce back, and be careful of answers that either do too much or do nothing at all. Choose your answer, and we will reason through every option on the next slide. Let us break down this answer. First, see the setup for a bounce back. He is medically stable, but the STEM tells you 2 things that matter, which are that he lives alone and that the team just changed 2 of his medicine doses. That combination is a classic recipe for confusion at home and a return trip to the hospital. Now, the key distinction between the choices. Reconciling his medicines and arranging follow-up within 1-week attacks that risk head-on, and it is both the cost-effective and the correct answer. Repeating an echocardiogram in a stable patient adds cost without changing anything. Keeping a ready patient 2 extra days just to observe wastes resources and exposes him to the harms of being in the hospital. and discharging him with only call if you have problems does nothing to prevent the readmission you are trying so hard to avoid. The correct answer is to reconcile his medicines and arrange follow-up within 1 week. Here is a critical exam day pearl that ties all of these ideas together, and it is the value tiebreaker. First, when you have narrowed a question down to 2 choices that both seem medically reasonable, use cost as your tiebreaker. This exam is deliberately written so that the safer, cheaper, less invasive option is the intended answer far more often than not. If one choice reaches the same goal with less testing, less cost, and less risk to the patient, trust that choice. Second, learn to spot the overkill trap. The most tempting wrong answer on a cost-effective care question is usually the one that sounds the most thorough, such as a fancy scan, an immediate procedure, or an admission. Remember that on this exam, doing too much is wrong, just as often as doing too little. When an answer feels impressive, but the patient does not clearly need it, that feeling is your signal that it is the trap. Choose proportionate care, and let value break the tie. That wraps up our review of cost-effective care for Step 3. Remember the core ideas we covered today. Use the choosing wisely mindset and ask whether a test would actually change management before you order it. Avoid unnecessary testing by respecting the absent red flags and refusing to repeat what is already known. Default to the generic when it is equivalent, and fix the cost barrier when a patient cannot afford a medicine. And reduce readmissions with careful discharge planning, medication reconciliation, and early follow-up. When 2 answers both work, let cost break the tie and stay alert for the impressive overkill trap. The best way to lock all of this in is to drill questions in your question bank under timed conditions and read every explanation, even on the ones you got right, backed up by a trusted review resource. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.